I'm Greg Johnson. I'm director of the Walter H. Capps Center for the Study of Ethics, Religion, and Public Life here at the University of California, Santa Barbara, where it's a cloudy day, but nice in general, of course. Most of all, we have students back on campus. I was out walking about earlier with my mask on, and it was just wonderful to see students out and about. I was speaking with someone earlier today saying, it feels like a moment of real opportunity, a moment of receptivity on the part of students that they, as much as I've ever seen in my career, I think, are here eager to learn. This is a wonderful moment that we all need to take stock of and appreciate. Of course, we're worried, we're anxious. COVID is quite literally in the air with us still, but there is a hopefulness, and I think that's one of the themes that will come through today. So I just wanted to pass on that sense of enthusiasm for what we're beginning to see on campus. That said, the events here at the Capps Center right now, we're still obviously in the Zoom world, and we thank you for bearing with us. I would so much rather be in person, welcoming you, perhaps going out to eat afterwards. That day will come as soon as the end of the quarter, we hope, but we're not there yet. So please stay tuned and bear with us as we continue down this path. But the good news, of course, is we can beam people in who might not otherwise be able to join us, as is the case tonight. So we're going to seek to maximize that. In that spirit, let me tell you just a little bit about our fall offerings. In October, we are delighted to be able to report that Professor Patricia Limerick of the Center of the American West at the University of Colorado will join us. She is one of the people who's most skilled at bringing the university and public audiences together to have hard conversations about such things as water in the West, water use, water rights, fracking, voter rights, etc. And I've, in some ways, apprenticed myself to her to learn how to facilitate these kinds of conversations. And in the course of that relationship, realized she's someone I want to speak directly to our community here at the Capps Center to help us think aloud and together about how we do this hard work of staging important conversations where the university is not set aside, but is very much part of public daily life, and people feel enfranchised. November 9th, we have Bradley Onishi from Skidmore College visiting us. He hosts a website, or I'm sorry, a podcast called Straight White American Jesus. This is about Christian white nationalism and the problems it presents to us all. And this is actually hosted through the Capps Center website, so take a listen. Professor Onishi is a wide-ranging scholar, and this public work he's doing to facilitate this kind of conversation about where did Christianity in this inflection go and what's at stake for all of us. This is going to be fantastic. Please tune in November 9th. By the way, you can find these dates in the chat in a document. We're still working on specific times and whatnot, so find our website for that information. Then finally, on November 16th, we have a new professor here at UCSB, Professor Lisa Sideris in the Environmental Studies program, joining us in conversation about religion, ethics, and the environment. And it's an honor to be able to welcome her and to talk together about what's at stake with these issues and what the promises are here at a place like UCSB. What's the work to be done? Please join us for that. Okay, a few more thank yous. I want to thank our staff, Maeve Devoy and Alma Mendoza and Madden Westlake for the work they do to make these events happen. I want to thank our donors. Without them, we couldn't do this. And I want to thank the Medical Humanities Initiative for partnering with us on this important event tonight. I want to make a land acknowledgement. We here at UCSB are on the lands and waters of the Chumash peoples who've been here for millennia and are still here. It's important that such acknowledgements are now standard. But it's also important that we go beyond mere acknowledgement, mere performativity. And we at the CAP Center are doing our small part in that. I've recently been elected to our campus repatriation committee. This is the committee that oversees the return of human remains and cultural objects to the tribes from which they were taken, in our case, largely the Chumash. And I'm honored to be able to do that work and form relationships. And then the question will be, what's the follow-on from that? Can repatriation help find us a way into something more like reparation, more like genuine connection and engagement and responsibility? I'm very invested in this. I look forward to bringing the CAP Center into this work, so stay tuned, please. Tonight's format. So after I make our introductions, I'll welcome Dr. Griffin in to give us a brief update on how he sees the lay of the land today by way of COVID and responses to COVID. Then Professor Hom will join us to facilitate a conversation with Dr. Griffin around the questions in front of us around translating scientific and clinical experience for community well-being, taking us through questions having to do with rhetoric and persuasion and discourse, so forth. Then we will shift to Q&A at the end. So please be posting up your questions. That function should be on, and that's our agenda. This event is being recorded. You will be able to find a link to it on our website at the Walter H. CAP Center and also on UCTV. So with that, I would like to welcome onto the screen our guests, Professor Malia Hom and Dr. Daniel Griffin. Welcome. Awesome. Thank you.
Hi, nice to be here.
Thank you both for making the time to do this with us. I think starting the school year off with a frank conversation about where we are and what we should be fearing and what we should be hoping for and how we talk about these things. This is critical. And so we're grateful. Professor Stephanie Malia Hom is Assistant Professor of Translational Italian Studies in the Department of French and Italian. Professor Hom served for 4 years as Executive Director of the Acus Foundation, a Berkeley-based nonprofit that provided integrative medicine training to healthcare professionals serving veterans and their families. Her experience working with physicians and patients navigating healthcare systems in the US has driven her interest in the medical humanities with the aim of advancing compassionate care. And Professor Hom, I want to extend a special welcome from one newcomer to another. I trust you agree, it's great to be here on campus finally, in the community finally. So let's make the very best of this. So thank you. Dr. Daniel Griffin, MD, PhD, is a physician, scientist, researcher, clinician, and author. Certified in infectious disease with expertise in global health, tropical medicine, parasitology, HIV, and virology. He is chief of the Division of Infectious Diseases at ProHealth Care, a member of the Department of Medicine Division of Infectious Diseases at Columbia University Irving Medical Center, and president of Parasites Without Borders Incorporated. Dr. Griffin co-hosts This Week in Parasitism and is a frequent guest on This Week in Virology. And by the way, do yourself a favor, listen to This Week in Virology. If you wish, it's a podcast. If you wish to have a quick primer on what's happening, not yesterday, but today, and not anytime today, but right now today. It's that current, Dan. Dr. Griffin, I find it really fantastic. And so glad you're both here. I'm going to turn it over to you all. And Dr. Griffin, why don't you introduce yourself with a quotation and tell us where we stand.
All right. Well, thank you for that kind introduction. I'm actually very excited about this. I spend a lot of my time talking about the science of COVID. And tonight, I think we're going to get, or this afternoon, or tomorrow morning, if you're listening in Europe when you wake up, this will be our chance to talk a little bit about the human side of this crisis. So I often start my weekly podcast, This Week in Virology, with a quotation. So I thought that would be appropriate to set the tone for us now, as we have a lot of questions, a lot of fears about the future. So, nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. And that's Marie Curie, or Marie Salomea Sklodowska-Curie, originally from Poland. And hopefully that gives us a sense of where we're going to be going tonight. We're going to be talking a lot about, well, more than just the science of COVID. But as people are well aware, COVID, the pandemic here in the United States, has really transformed from early hotspots, New York, California, now to hotspots where we're seeing, the South, we're seeing Florida, we're seeing Texas, Alabama, Mississippi. It's also transformed from a disease of our most seniors to our youngest. Right now, we're seeing about a quarter of all the new cases actually are in children and adolescents. And when you even break down that number under 18, the highest hospitalization per capita is actually in children under 4. So this pandemic has really gone through different cycles here in the US. And we go outside our borders, it's a crisis like we've never seen before, not just COVID itself, but the impacts on global health, the impacts on tuberculosis, on malaria, on all the many neglected tropical diseases, which are really even more neglected now. But I think I'm talking at a really positive time. The United Nations is meeting today. It's meeting actually for 2 weeks here in New York City. And we're hearing that there's really a commitment and optimism that what has happened so far is not what is going to continue into the next year. We are looking at efforts, at commitments to getting enough vaccines, and not just the vaccines, but everything that it takes to get those vaccines into arms. We're also hearing that there's going to be more tools that we can bring to combat COVID, not just vaccines, not just these expensive monoclonals, but pills, oral therapies. So I think that we have been through an incredibly tough time. We still are in a tough time. Here in the US, we're seeing over 100,000 new cases every day. We're seeing over 2,000 deaths a day. But I think there is light. I think there's optimism on the horizon. And hopefully tonight we will I'll be able to share a better understanding of what has happened so far and what the future holds. So I'm going to stop there, and I'm going to let Stephanie drive the bus from here going forward.
Thank you, Dr. Griffin. And thanks to all of you who are out there watching this webinar right now. Many thanks to the CAP Center for this wonderful invitation. And I'm very pleased to be here this evening. Dr. Griffin, I was interested in hearing your thoughts. What's been so unique about this pandemic is that it's not just a pandemic in the medical sense, but it's been an infodemic at the same time. That is a pandemic of misinformation and disinformation. And as a practitioner, how have you navigated this, one from the medical side, but then also from the side of mis and disinformation, this infodemic?
Yeah, I'd like to think that this was new, that this had not happened before, that this was the first time that there was a virus that had a friend, and that friend being all this, well, maybe more than just one friend, lots of friends seemingly spreading misinformation, but actually disinformation, people knowingly spreading information that is untrue. And actually, that was my commitment. That was our commitment early on in the pandemic. In March 2020, I spoke to Vincent Racaniello. He and I are directors of an organization, Microbe TV. He's also part of Parasites Without Borders. And we realized, we need an independent, objective source of information. We need a source of information that's not political. And I'm fortunate, and I have to say that, just very fortunate to be in a position where I have no boss that says to me, "Ooh, you can't say that." I do occasionally get emails from people on the Biden task force or people at the NIH saying, "Well, our message is sort of this way." And my response is always, "Well, the science is this way." And so early on, we've made this commitment to be a resource. And so Greg gave a little bit of a plug for us. But I think we realized early on, and I think it's become really clear over the last 2 years, it's really hard to get honest information because people have agendas. And I don't think those agendas are necessarily evil agendas. A lot of them are well-intentioned, but they're agendas nonetheless. There also was I'm going to call it paternalism, this idea that the populace was really not ready for the truth, this idea that we were talking to people with 5th grade educations. But I think that people are desperate to be educated up. People are desperate to learn. And that's really how we've faced this. I think if you try to simplify something, if you're not completely honest, people remember that in today's age. That those sound bits, those are recorded, those are there for eternity. So a commitment to honesty, always being honest, to respecting the audience. I'm hoping that there's a lot of silver linings that come out of this pandemic. And one of them, I hope, is better science communication.
Thank you. No, I think one thing I thought of as you were speaking, in the last year, my first year at UCSB, I taught a course on the pandemic, on biopolitics and the medical humanities. And one of the things we talked about, this was 6 months into the pandemic, we talked about the idea of complexity mismatch, that there was information siloed over here, information siloed over here, and there wasn't too many people brought together to be talking. But one thing I think now at this point in the pandemic that we're seeing is this incredible amount of cooperation. And have you seen that in your practice, in your clinical practice, and talking to all these different sources?
You know, I feel like it's gone through several cycles. There was an early cycle, which was very frustrating. A lot of people, you know, sort of feeling like we don't really want all these numbers because the numbers make us look bad, right? You know, and there were governors that we now realize in retrospect that maybe we're not completely honest with the numbers of what was exactly happening in their state, because everyone was being judged, right? Then there seemed to be a point when it became clear that that information was going to be out there, at least to a large extent, maybe not completely out there. And then there was you know, thinking of stages of grief or something as we went through the stages of the pandemic. But then there was sort of this acceptance, like, okay, the numbers are real. We don't make people sick with COVID by doing a test. We just identify a person sick with COVID by doing the test. And then there was really, I think, a very heartening time where I saw all across the board, and even one of my jobs that Greg didn't mention is working as the senior fellow at United Health Group. And I saw this large behemoth, 7th largest company in the world, basically say, forget about the business model. What can we do to help? And so there was this really sort of golden, wonderful age where people, it was all hands on deck. Well, it's over now. Let's get back to business as usual. And things started to change. A lot of the funding was drying up. Things were sort of getting back to business as usual. I think now it's happened again where people have realized, wait a second, when the mask came off, when you have half a country still unvaccinated of the eligible adults and all these children unvaccinated, we really need to continue with that early, whether it's altruism or whatever it was. But I think we've gone through this cycle.
Really interesting. And I think, I wonder if you could speak to that of our response, these cycles we've gone through in the US, and comparing those to responses at a global level. Where are we now? And then where are we in relation to the rest of the world?
Yeah, I mean, it's been embarrassing, to be completely honest, how the richer nations have dealt with this pandemic. And, you know, I think it was about a month ago, I was looking through where we were with global vaccination. And if you look at the low income countries, less than 0.5% of all vaccines had gone to low income countries throughout the world. I mean, that's just, it's a tragedy. And we're only now really seeing when the United Nations is getting together, that there really is this commitment. I mean, this was this model of, you know, you're on an airplane, put that oxygen mask on your face first. And then no one did the next step. No one then started putting it on the people around them. They wanted 3, I guess. And so we're only now seeing this real commitment. And it really, I mean, it echoes a lot of colonialism, a lot of these other ideas where initially Gavi was set up, this cooperative idea that we would share vaccines, that we would make sure that there was equity here, that we would realize we were a global community. We did not see that. We actually saw the wealthy nations getting the majority of the vaccines. Here in the US, we have, you know, millions of vaccines going bad on shelves every week. I mean, it's really, it's an embarrassment. It's a tragedy. And I talked to my friends in sub-Saharan Africa. I talked to my friends in India and Southeast Asia, and they are so desperate for vaccines. And here we're paying people. We're giving them lottery tickets if they go ahead and get a vaccine. So this is going to be, I think, remembered as a bit of an embarrassing time for how we behaved. And hopefully we can make amends over the next year.
Yeah. Well, that brings up the question of booster shots too. It kind of gets to the heart of it. If vaccines are going bad on the shelves here and most of the world has not yet been vaccinated, what are the ethics behind booster shots in this sense?
I think it's pretty clear how the WHO feels about this. And the science is not compelling, to be honest. I know that there's been this rhetoric around, we can chew gum and walk at the same time. It's a false dichotomy, the idea that we can vaccinate the world and vaccinate ourselves. But we didn't do that. We're only starting to do that now. While we were focused on vaccinating ourselves, this tiny percent of vaccines were getting to other nations. And so when certain areas decided they wanted to start doing boosters, there were vaccines that were diverted from sub-Saharan Africa. I have a friend in Blantyre, Malawi, and they were expecting their shipment. And then there was news that certain areas had decided that they wanted boosters. The way the contracts were written, those vaccines were diverted. Right now, the vaccines are here. There's 1 billion vaccines in the United States. I'm not sure if boosters impact that, but I'm hoping maybe, the fact that we're going to do boosters really makes us pushed to do things for the rest of the world. And maybe there's a politics to that. It's hard to convince your population that their tax dollars should go to take care of the rest of the world if they're frightened, if they're concerned, if they don't feel safe. I'm hoping people in the United States now feel plenty safe, that we can really focus on the rest of the world. And I think the message that we're sending, which is really true, is that no one is safe until everyone is safe. Where did the Delta variant come from? It came from India. Where's the next variant going to come from? It's going to come from unvaccinated areas of the world where the virus has its opportunity to reproduce, to replicate, to change, to mutate. So maybe I was saying the other night, and my daughter Daisy was like, wait, what did you say, Daddy? I said, yeah, the most selfish thing we can do right now is vaccinate the world. And she was like, I thought that's what you said. And I was like, it is true. The most selfish thing we can do is vaccinate the rest of the world.
That brings up another question. I want to come back to kind of the bioethics of that in a second, but I wanted to ask you, because you mentioned about potential future variants, how this virus might evolve, and your experience as an infectious disease expert. Can you run through some scenarios for us? So we can have an idea of where this might go.
Yeah. So this is in no way new. And maybe to give our listeners some background, I grew up in Greenwich Village in the early 80s. My mom was a painter. We lived in an artist co-op. And it was really a population. Our community was mostly, single gay men. It was, there was this wonderful nightlife. And then something started to sweep through our community. And really in a matter of a few years, about 90% of our neighbors died of what we now know as HIV/AIDS. And the first drugs started to be used in this population. And very quickly, if you used a single drug, HIV would mutate away and you'd lose that drug. And then you went to a second drug and finally a third drug, maybe even a fourth drug. And then we started to realize you needed to hit this virus with several drugs at once. Otherwise it would mutate away. We had a bit of hubris early on with COVID with the idea that, well, this is a virus that doesn't change so quickly. Well, it may not change so quickly until you let 1 billion people get infected. And then, a small percent of 1 billion suddenly starts to become a large number. And so, we've seen this before. And I think that's critical going forward. It's very clear that this virus will change. This virus will continue to go through the Darwinian selection of the fittest variant. And we've seen several cycles. We saw the alpha, we saw the beta, we skipped a few, right? Now we're up to gamma and mu and others that are out there. Right now, Delta actually seems to be the fittest one in most parts of the world. But there are a number of mutations, and actually a researcher, I'm getting into the science now, a researcher here in New York, Michelle Nussensweg, his parents are actually very famous malaria researchers. They've looked at the spike. That spike can basically mutate away so that currently people with 2 doses of vaccine will become susceptible to this. So that's part of the thought of, do we need a third dose? Really, is the mRNA vaccine ultimately a 3-shot? Maybe the J&J is ultimately a 2-shot vaccine. So we do have the technology to combat this, but it is really dangerous to let this continue to propagate in so many parts of the world. Also, just the humanity side of it, right? I mean, these are human beings, right? And I think it was Paul Farmer who talked about the fact that, if you value one human life over another, that's just sort of the beginning of the end. And that's sort of the source of so much inequity and so much suffering in this world. And I think we need to realize that these are human beings, these are children, these are people with families that are dying every day.
And that gets right to the heart of what I wanted to bridge, was this question of biopolitics that's at the center, that this idea defining biopolitics as the sphere in which politics intervenes in biological life. And the two fundamental questions to that are, what is the value of life? And two, who or what has the power to value life? And in the course I taught last fall, we were examining these questions. And the great example of it was the moment that Trump was diagnosed with COVID, and then immediately was able to get the antibody treatment that was unavailable to anybody else. So what is the value of a life? Is the life of the president more valuable than somebody else's life? And who or what has the power to value that? And in your practice, in your everyday practice, I'm sure you must run up against these scenarios all the time about making decisions about patients, or, I guess also in the question about vaccine nationalism, that's where this comes up, right? How are we valuing life? And I just wanted to hear your thoughts on that, from being in the trenches and clinic, but also being on the policy level too, because you're seeing two different sides.
Yeah, I mean, that's sort of nice, I think, from this pandemic, having the perspectives of each level. So, most of what I do each day is take care of patients. So that one-on-one, physician-patient interaction. And it's clear during this pandemic that if you are a wealthy white male, your access to medical care is quite different than if you're unable to speak English, if you're Hispanic, if you are from a low socioeconomic position. And we saw, this is, what is it where, we're all in this storm together, but we're not all in the same boat, right? I mean, there's some people who are weathering out this storm, telecommuting, working from a nice, comfortable home with a high-speed internet connection. There's other individuals out there who are, packed together in the front of a pickup truck getting to and from the landscaping job. And so, we saw just at the exposure that there was a difference. And then when they would show up at a hospital unable to speak English, what was the chance, even now that we have access to free monoclonal antibodies during that first week with this tremendous, what's the chance that that Spanish-speaking individual will even be aware, right? So there's an educational issue. They're going to have a primary care doc who's going to connect with them and get them access and make sure they get the optimum treatment. It's clear during this pandemic that, right now it's a pandemic of the unvaccinated, but it's always been a pandemic of the disenfranchised, of the people who are socially and economically and otherwise disadvantaged. And if you look at, the other day, statistic came out and said, 1 in 500 Americans have died. Well, if you break that down and say, well, what about Native Americans? It's about 1 in 200. That's completely different. What is it if you look at, wealthy Caucasian? It's not 1 in 200. It's a much, smaller impact. So I think that as much as we talk about these inequities, this was really a magnifying glass that we are not doing a great job.
Absolutely. Yeah. And it raises the question too about, the gendered burden of care of the pandemic too. I think women have been also quite impacted by this, having assumed, the caregiving responsibilities, that have been huge. More women than men have left their jobs during this pandemic. And so I think you're absolutely right that this pandemic has amplified disparities that were already existing, particularly here in the US. And I wanted to ask you too, one of the segments of our population who's been incredibly impacted by this pandemic are our healthcare workers. And I think what we're going to see in addition to this pandemic is the post-traumatic stress amongst all the healthcare workers as a secondary epidemic that's following on, tying into mental health and everything. And I was wondering if you could speak to that, about physicians burnout that they're feeling. I've been reading about compassion fatigue that that clinicians are experiencing. What has been your experience in the day-to-day?
Yeah, I could definitely speak sort of my personal impact, but I want to sort of stretch it a little broader, Stephanie, because a lot of times we talk about healthcare workers, physicians had it pretty good by comparison to our healthcare colleagues. I look at my colleagues that were aides, that were nurses in nursing homes and long-term care facilities. They did not have adequate personal protection. They were getting infected at a much higher rate. A lot of the hospitals were quick to give the N95 protective masks to the physicians while the nurses were walking around in surgical masks. So, it's hard. I mean, I feel embarrassed to talk about how traumatic this was for me, to just see by comparison how hard it was. I mean, the nurses are the one, right? Hands-on, changing someone when they've soiled themselves. It has just been tremendous. I mean, just to sort of talk about my perspective, I remember early on in the pandemic, and this is a story I told before, where there was a cardiologist, and he was sitting at home sort of desperate, like, what can I do to make a difference? And so he was cross-trained to work as a critical care physician. And so, the rest of us had been there in the critical care unit, and this was his first morning. By 9 a.m., 4 of his patients had already died. And this is something, as a cardiologist, he just had not experienced before. And, he got through the day and then went home and just sat in his car in the driveway and just cried. I mean, it was just emotionally too much and, very hard. You're living in this world that a lot of other people just can't understand. And it's very hard to come home to your family and try to explain, what your day has been like. Last week was actually, I was taking care of a patient who was the mother of one of my colleagues, and she died. And it's just, hard now for so many people. The pandemic is over, but people are still dying. For so many of us, this pandemic is still going on. There's still so much loss. And now it's a bit more painful, I have to say, because there's vaccines. Every one of these deaths pretty much is preventable. A couple, 2, 3, 4 people a day die who are vaccinated, but 2,000 die a day who are unvaccinated, who could have been vaccinated, but didn't because of either misinformation or disinformation, or they didn't have access to the vaccines. And get back to the inequity, my mother had a fall and she had fractured her sacrum, and she had some home aides helping her. And I realized they were unvaccinated. And I asked one of them, as a woman of color, I said, well, why aren't you vaccinated? And, she explained, I have 2 jobs. When am I supposed to get vaccinated? I work this job. I don't get off until 10 o'clock at night. And then I start my next job at 6 a.m. And here's this woman who's working in this, and she's not, she's working for one of the largest healthcare systems in the state, but yet they were not providing special after hours access to vaccines for their staff. So really, I mean, so many levels of this are just really traumatic. There's Taylor Swift's song, if people like Taylor Swift. This is not what they taught you in med school. This is so much beyond that, so much loss. And then the horrors of the loss, these people are dying alone. These people are dying with their only access to family being through an iPad or FaceTime. Maybe now we're able to get one person at a time to be there with them. So just the tragedy of watching, fellow human beings die alone is just, it's horrible. It really is.
Yeah. Yeah, I mean, it's put even more distance between our experience of death in this country, which is already distance. It's adding one more layer to it. And I think the point you raise about this tremendous loss and the grief that people are going through or not going through, right, or delaying it until the future. I read a statistic last year at around this time of the pandemic that 1 in 9 Americans had lost someone to COVID. I'm sure that is now down to an even lower ratio. And so, this idea of both individual and collective grief that we are and will be experiencing in this nation for years, if not decades to come, is something that is rarely broached because we're so still deep in the middle of the crisis. And I think thinking about that, the mental health aspect, the physical aspect of the pandemic, if the United States was your patient, what would be your diagnosis and treatment plan today?
Yeah, we're pretty dysfunctional. We're in pretty bad shape. I think the first thing that you pointed out about this mental health challenge is, unfortunately, there's a disparity here, right? So a lot of wealthy, privileged individuals have not had someone personally die. They were able to weather the storm in comfort. It didn't touch them. So I think it's really created more of a divide in the social health of our country. It's going to be tough too, because if anything, people would have thought going into this that, a common enemy, if we could face this common enemy together, it would bring us all together. It really hasn't done that. So I worry about the health of my country, seeing that if anything, this was seen as an opportunity for many people to get political clout by going, to either extreme with this. I worry, I'm going to blame social media and other, because when we look at it, there's this illusion that there's these anti-vaxxers, these rabid them. But if you look around, most Americans have jumped on, already gotten at least that first vaccine if they're eligible. I think there's a lot more in common, across our country than divides us. But that division has been magnified because there's a certain political aspect to it. People buy more newspapers when you tell them, scary stuff. Stay tuned. They don't buy the newspaper when it's, good news on the horizon. I do think that, we will come out of this as a country healthier. I do think there's a lot of lessons here to learn. And what are those lessons? Why will we be healthier as a country? I think it is transforming healthcare. I think that access to telehealth services, which can allow us to reach out to farther parts of the country, reach out to rural parts of the country that have previously been underserved. We've realized how to do this well. There's a lot of new paradigms to medicine where we've sort of said, well, what was the old paradigm? What can we do to get better? And the ultimate health of our country, I think in a lot of ways is going to come down to that, not just physical health, but also mental health. And I think we're realizing too, that mental health is really an integral part of our healthcare system. And I hope we come out of that, embracing that, continuing to accept that.
That's really interesting. And it brought to mind, you were mentioning kind of language and this idea of maybe we will unite around a common enemy. And one of the things with military rhetoric. It's a war on COVID. Doctors are on the front lines. We're battling cancer. We're doing so on and so forth. And I remember there was a book by a physician named Bernie Siegel who wrote about love, medicine, and miracles. And in one of the chapters, he talked about reframing that language where it's no longer a battle. And he had a cancer patient who did a visualization of chemo, instead of killing the cells, kind of englobulating them in love and melting them away. And that shift in mentality and perspective seemed to have a clinical result in this patient. In your thought, is there a way we can shift the rhetoric around the pandemic that will help us to come together, not necessarily around a common enemy, but perhaps around something else?
Yeah, no, words matter. The other day I was actually talking, maybe this was to Eloise, about why is everyone always fighting for me? You read the magazine, we were down for Parents Weekend, you see on the TV, we're going to fight for, everyone's always fighting for us. And that's really like not what healthcare is about. Your doctor shouldn't have to fight for you. Why would there not be good access to the treatments that you need? Your doctor should be working with you. It should be a cooperative. Maybe there aren't enough women in medicine, Stephanie, to be honest. These are all like very violent metaphors. And when you come down to it, the patient-physician interaction, the pursuit of health is much more of a cooperative, much more of a nurturing, much more of a maternalistic approach. And so, yeah, the rhetoric, the words, it's quite different. I had a patient today who I went in to see. And there's all this rhetoric now about like, rationing care and physicians, it's so hard for them to take care of the unvaccinated. And I'm like, well, it did seem very foreign to me. And I went and saw this woman, and I could see she's in the ICU. She's on the high flow oxygen. She's a Hispanic woman, overweight, in her early 40s, but quite ill, unvaccinated. And she obviously was frightened. And the interaction was not about fighting. It was about connecting. It was about holding her hand. It was about hearing her fears. I mean, that's what physicians do. That's what happens at the bedside. We're not fighting. We're connecting with individuals, and we are working with them in a cooperative, nurturing manner. So I think a lot of this rhetoric is just inappropriate and not helpful. We're not fighting. This is not a war. And I think that when you have that, you have sides and all the rest. But I think that, yeah, it would be really positive if the rhetoric, if the perception could change.
Yeah, we could start an infodemic of compassionate rhetoric. And absolutely, I mean, I think the stories that are circulating in the media also go through these type of cycles. So, I think at the beginning, the point I'm getting to is politicization of treatments. At the beginning, we had this misinformation about, oh, you're going to take, drink 10 gallons of water a day and you'll ward off COVID. These kind of folk cures or preventative treatments. And as the pandemic has gone on, we've cycled through these kind of stories, these kind of information, this sort of second, third hand, fourth hand information. And I was wondering, part and parcel of that is also this politicization of treatments. Right now, I think we're seeing it with ivermectin, the anti-parasitic drug. And I wanted to just hear your thoughts about how treatments and treatment plans are being politicized and what's showing up in your clinic.
Yeah, this is a huge problem, and it was a problem from the beginning. And I think it's very human. You want to be right. You want to be able to say, I knew that. I always knew that. And science is not about always knowing it. If anything, it's about humility. It's about saying, we do not know. I do not know. The other day on one of these popular podcasts, one of the physicians was saying, we are going to do the science, but we already know how it's going to turn out. We actually don't. That's the humility. I mean, 90% of the things we try actually don't work. And that's why we try them in a proper way so we can actually get that knowledge. And from a physician, right, this was very disturbing because early on, we'll say March 2020, here in New York, when it became clear that we were in the middle of this horrible pandemic, there was this kitchen sink approach, this idea, and I remember talking to a physician I really respected, why are you doing all these things? And his thing was, because if I look back and I didn't try what we later realized worked, I will feel terrible. And I responded with, well, what if it turns out you're doing things that are increasing your patient's chance of dying? And his response was, well, but it was with good intentions. And so we now, as we look back, probably 10% more people died because we used hydroxychloroquine than would have died if we kept our hands in our pockets. We now realize that people using steroids in the first week probably increasing mortality by 35%, where if we do it during the second week, we can reduce it by 25%. Right now with ivermectin, there were a couple early studies that were really exciting. And then we realized those studies were never actually even done. There was a study in Egypt that we looked, it never happened. There was a study in Peru. When they went to the hospital, they said that study never happened here. So it's a very, very frightening situation, but they've all been politicized, and we have maybe a short-term memory, but this is sort of, you saw the governor getting up every day, giving you a governor's update. You saw the president with his daily press conference. Why were we listening to politicians when the whole issue was medical? Like, would you go to see the president if you had a medical problem? No. Would you take your car to the mechanic? You go to see a doctor when you're sick. So it was sort of interesting, in all honesty, that, we did this. We tuned in to watch the president. We tuned in to listen to the governor. So we tuned in to the wrong sources. And that actually was a lot of our effort at Parasites Without Borders, at Microbe TV, with This Week in Virology. We offered an alternative. We said, you know what, it's not as exciting. We're not going to talk about swallowing, flashlights or batteries or bleach, but we will talk about what we know, what we don't know, what we're learning. Science takes time. It's not as exciting as someone who's got the snake oil that's going to fix you tomorrow.
Well, and indeed, medicine really is an art many times more than a science. The ivermectin case is interesting to me because the reason, I think it was last week, there was an Ohio court that actually legally ordered a hospital or a doctor to prescribe ivermectin to a patient. And here we have, this legal apparatus intervening into medical care. What are your thoughts on that?
That it's very disturbing what has happened. And I think that's been in the media. So that was very clear. Does a judge, does a lawyer know what the best treatment is? I mean, that's sort of, a whole nother level. And we even, at a level, I think that disturbs me, we have a lot of hospitals, healthcare systems with committees getting together, creating guidelines, deciding how all the patients should be treated, maybe even in conflict with what's, recommended by like the professional societies, maybe even what's in conflict with what the literature shows and what the science is showing. And I think there's a dysfunction across the board. I have a friend, a physician in Idaho, and they had someone elected there to one of the medical bodies who is anti-vaccine, pro-hydroxychloroquine, even now, in late 2021. So it's just, there's some disturbing issues. Now, the ivermectin is tough. We are setting up to do clinical trials. We're trying to figure out, is there a role here at all? They tried to do ivermectin trials in South America, but they couldn't do them because everyone was on ivermectin. They couldn't have a placebo group because everyone had decided ahead of time, sort of this hubris, we know what the science will show. If you can't do the science, you don't know. The human body is incredibly complicated. And until you do the science, and the science is very simple, these people get it, these people don't. We make sure that they're similar populations, and at the end of the day, we find out who did better. There's nothing mysterious. The anti-science movement, I think, doesn't quite get just science is straightforward and things like that. But we haven't been able to do those trials. And hydroxychloroquine went through this, it became, your team is for it, your team is against it. It became partisan. We were fortunately finally able to get those trials done. And we realized that actually it was not helpful and that it was harmful. But it's actually been really difficult. In the US, we've not done a great job. The UK with the recovery trials, they gave us steroids, they gave us tocilizumab, they gave us anticoagulation, they gave us so many of the things that we now do. We in the US did not do such a great job.
I think, part and parcel of it too is the scale and speed at which this pandemic has evolved. I mean, I think science, takes time as well, just setting up all of the trials. And how much of it do you think, you had mentioned earlier at the beginning, it was kind of the kitchen sink approach, like we'll throw everything at it. How much of that do you think is still holding over at it, or perhaps it's not? What do you think?
So in some places it's gotten better. I mean, I think in a lot of parts of the country, people have sort of stepped back and realized that, hey, we actually may have hurt people with this, and I think that it's not about how you feel as a physician, it's about what you did for the patient. It's about how the patient does. So I do hope that a lot of physicians, because of this pandemic, will not make the mistake. Should we have another new disease? I mean, we're predicting another pandemic, by the way. This wasn't even the pandemic we expected. We were thinking it would be an influenza pandemic, so that's still on the horizon. So my hope is that a lot of physicians learned from this. And next time they won't just do things. Also, some stuff, this could be optimistic. So the monoclonal antibody treatment you mentioned with President Trump, when they first rolled that out, they did the trials in people who'd been in the hospital already for about 3 weeks. It made no sense. I actually was on a call with one of the people at Regeneron because I had developed a monoclonal antibody back in the 90s. And we had a conversation. We said, why are you doing this? It makes no sense. And the response was, well, we only know how to do trials in hospital patients. We've never done them in the outpatient setting in that first week. We said, well, that's no reason to do a trial that you don't think is going to work. Let's make this happen. And now we have networks across the whole country looking at treating COVID during that first week. And we think out of those trials, we're going to have effective oral antivirals by Christmas. And that took creating something that didn't exist before COVID-19.
That is really positive news, great news. And it actually broaches another question I had about so-called long COVID and the kind of, chronic disability that people are experiencing, both, after having had COVID. What are the prospects there for treatment and for outlook?
Yeah, so long COVID is tough too, and I think that hopefully this gets the whole medical profession to reflect on themselves. Is early on, weeks. And these were, for me, nurses, healthcare providers that I knew personally, that I trusted. And when they said, Dr. Griffin, I just don't, my hair is falling out. I can't think clearly. I can't walk up a flight of stairs. I believed them. And a lot of clinicians, unfortunately, were dismissive. And I go back sometimes and look at those notes from people now who are sort of on board. And that's the wrong message. That's the wrong dynamic between clinicians and patients, is to be, dismissive rather than trusting, rather than listening, rather than saying, I don't know, this is new. I don't know everything. That humility, I think, is hopefully going to be part of medicine going forward. Hopefully we've learned from this pandemic a bit of humility. But with long COVID, it is now recognized. There certainly are some people out there saying dismissive things, but that's the fringe. That's not the mainstream. The NIH has recognized this. They've given it a name, the post-acute sequelae of COVID, or PASC. Within that large umbrella, there's this subset of this syndrome of long COVID. There's now $500 million that was given to NYU to set up and orchestrate and do subgrants to look into this. There's a lot of top researchers trying to understand what's driving long COVID. Some of the first things we observed, which was encouraging, is that a chunk of these people get better post-vaccination. We're not sure what the mechanism is there, but there's really a commitment to systematically investigate this, to create trials for these individuals so they can be part of the solution, so they can participate. There also, I think, is a bit more respect. This is not just we are running the trials. There's much more of a cooperative relationship. And a lot of that was driven by a group, Survivor Corps, actually, that started right here in Port Washington. And it was a mother, actually the mother of a daughter who's in the same class with my son Barnaby, and she got sick with COVID early on, and she sort of took that on as a grassroots, and it grew into 200,000 supporters. And this is, I hope, going to be a model where there's a cooperation between the patients and the researchers and the clinicians, and not, again, this is going to be transformative, I hope, for how we do research and how we treat research participants.
Yeah, that's good to hear, because long COVID for so long, patients have been dismissed. Oh no, it's all in your head, we're not, and it's really about, what you said, it's about listening. It's about the job and listening to patients and building that trust and establishing that trust. And I think what we've seen too in this country, patients who've had COVID, with physicians and healthcare workers who've treated, and everyone involved, there's been this incredible resilience in our country, in addition to, all of the dysfunction at the same time. Some of the stories you hear about, nurses in hospitals, healthcare workers, everything. And you had mentioned, these, I think that resiliency is one of the real positive aspects coming out of this pandemic. And I look at the case of Italy, for example, which is one of my regional specialization. There's been incredible resilience in that country, in terms of being one of the hardest hit countries in March 2020 to where they are today. And I wanted to hear your thoughts about resilience, positive changes that have come out of the pandemic, and what that might hold in store for the future of public health here in the US and globally.
Yeah, there's so much focus on the negative, right? Like what we did wrong, who did what wrong. Maybe that's very human. Who can we blame? But there's a lot of positive aspects. And, Italy just reminded me of the amount of communication that happened. I mean, early on in the pandemic, when it started in China and it started to spread to Italy, to the US, there was a lot of communication that we had as clinicians with our colleagues in China, with our colleagues in Italy. It was interesting because it was done like, they might take a black Sharpie and so you didn't know what institution it was because the institutions didn't want you sharing. But, we took an oath. Our commitment is to the patients. And so there was really a sort of a wonderful cooperative connection, a collaboration, an international collaboration. And I think those relationships are going to stay. I think clinicians around the world are now connected in a way we were not connected before. I think the other thing too is, you always hear the stories about the clinician burnout, the nurse burnout, but there also was an incredible bonding that happened during this time. So the relationships that we have with each other, seeing a colleague go through what we all went through together, there's a different respect. The way medical education was, it was often kind of harsh. But I think now there's more of a respect that, medicine has enough harshness built in, that there's kindness, there's more of a compassion. I think less of a professional hierarchy. I'd like to think that is being broken down to some degree. And so I think as much as we focus on how negative this has been and what went wrong, there's really a lot that we've learned. I think we're going to come out of this as a global community better. I do hope that we're a bit embarrassed about not sharing the vaccines. And as we go forward, as we use structures such maybe as PEPFAR to get those vaccines out there, that we've taken something that was built, we've expanded it. Hopefully that's a network that stays in place for the future, for pandemics, for other diseases, for all the challenges.
Excellent. Yeah, and it raises the question for me too. We're talking about the future, and it is very hopeful to hear that, yes, we are coming out of this pandemic. We will come out of it. And what I've been reading is that COVID is actually going to become endemic. We're not going to get rid of it, but when it becomes endemic, what does that look like for us in the day-to-day? How do we live with it?
Yeah, so that's a certainty. I don't think that's in dispute. I mean, COVID, the SARS-CoV-2 virus is here to stay. There will always be a certain population, certain percent of our population that either doesn't get vaccinated or can't become immune because whatever their immune system. But it's in the deer, it's in the animal, it's in the cats. It is here. But what we think we can do with vaccines, hopefully now with therapeutics, is turn this into more of a common cold. People often use the flu as a metric, and maybe there's something there. I think we're a little too content with 20 to 50,000 people dying every winter of the flu. But what we're seeing now is when vaccinated people get infected, there's a certain chance of dying, but it's probably lower than your chance of dying in an automobile. It's starting to get to this lower level. So if we can have vaccination across the board, if we can have effective oral antivirals, if we can keep pathogen. But I think this might be the silver lining. We may have to keep up globally vaccinating people on a regular basis. And if we do, that's going to create an infrastructure. And when something is there, we start using it for other purposes, right? No one uses their iPhone to make phone calls anymore. Suddenly it's turned into something we do so many other things with. We explore the possibilities. And so having a global vaccination network may be a network that allows us to do so many other things that we haven't even thought of, haven't even dreamed of yet.
Brings up the question for me of future pandemics too. So I think one of the greatest challenges, how do I frame this? In my course last year, one of the issues that came up with the students was the link between climate change and pandemics. And that the more that humans have encroached upon natural habitats, the more opportunities there are for zoonotic spillover, the more opportunities there are for new diseases to emerge. And climate change is, of course, one of our biggest challenges. So if COVID becomes endemic, and you mentioned earlier that influenza is being predicted to be the next pandemic, how, I think using these tools that you're mentioning, do you think we'll be able to manage a future pandemic better, learning from this experience?
So we should. And part of that is that vaccines have suddenly become cool again, right?
Mhm.
And there's efforts now to make vaccines against influenza that I'm going to say that actually work. People always say, like, they poo-poo the flu. I got the flu shot and I still got sick. Well, you didn't die of the flu, but no one seems to appreciate that. I wasn't going to die anyway. But now there is the technology, and a lot of this may come from mRNA, but it may even come from just the other platforms that now we're spending a lot of time, spending a lot of resources investing in. So one is, I think we have some really great plug and play vaccine platforms that we've developed, that we've refined, that we've studied, that we better understand. So we're going to have that. Also, I do hope this is true, that we're going to provide ahead of time pan-virus family therapeutics. The oral antivirals that I'm talking about coming out this fall before December, there's no reason those couldn't have been developed a few years ago, and those couldn't have been sitting there ready. Talk about a national security. We got hurt, worse in this pandemic than any foreign war. Actually, probably start combining them all, and by the end of this, it'll be close to 1 million Americans that have been lost to this pandemic. So the idea of investing in the research, so we have effective influenza antivirals, so we have effective rapid influenza testing, and what other virus you might be thinking about, that virus X. There's no reason that we can't, if we have the will, if our memory is not too short, that we can't invest in the research to have the rapid testing, to have the therapeutics ready to go with maybe little tweaks, to have the plug and play virus platforms where we now say it's 100 days from sequence to an effective vaccine. That is not where we were when this pandemic hit us.
That's just incredible and really positive. I guess right now I want to so we have a couple of questions in the Q&A that I wanted to bring up. Both of the questions are about long COVID. So I'm going to read both of them at the same time, and then Dr. Griffin, perhaps you can expound upon them.
Okay, certainly.
The first question says, I have had long COVID, and you're right, my well-intentioned primary care physicians don't know how to respond to it. My question is, though, how can I translate this into a workplace response, such as an accommodation or paid leave? So that's the first question about accommodation. The second question is, the symptoms of my long COVID have been hair loss, skin problems, fatigue, and brain fog. How can this be better understood? So
Okay,
first question about accommodations and paid leave, and the next about symptoms.
Yeah, so a big challenge is, well, it's a big challenge, but now maybe I'll say part of the solution is long COVID is now recognized as a disability. And so that's really positive. So that seems like it should be more positive than it turns out it is. It still is not easy to get someone any kind of disability accommodations when you say they have long COVID. And we have a large number of patients here in the New York area who have long COVID and are going through this rather onerous process. And yeah, no, this is difficult. And part of it is that there still is a portion of our society that's somewhat dismissive. They don't want to believe that this is a problem. But I'll say, when, my role at UHG, we provide United Healthcare insurance for lots of companies. I won't mention names. A lot of these companies, about 10% of the people at those companies who got COVID are unable to return to their pre-employment position. So this is really disabling. A lot of it, again, words matter. The concept of brain fog, we've now started trying to use the cognitive dysfunction just to really point out that this is a serious disability. This is not just, oh, I feel like I had a little bit too much to drink last night. This is unable to sign your name. This is unable to perform the cognitive tasks that you need to perform your job. Just imagine an airplane pilot with brain fog, cognitive dysfunction. What accommodations do you provide to allow them to get into the workspace? So this is a challenge. It's actually nice that this is being brought up because this is not resolved. And so what I often tell patients that I work with is you've got to work with your primary care physician. You've probably got to get a disability specialist to work with you because this is uncharted territory. This is not like MS. This is not like a back injury. This is not like a cancer where it's very understood. The other side, and this is going to be my hopeful thing, which we talked a little bit about, is we really do not at this point understand what is causing long COVID. And it's probably a number of different things for different individuals. It does seem to be some degree of immune dysfunction. Almost think of it as an autoimmune disease that has been triggered by COVID, but we don't know if it's because there's still a little residual viral antigen or virus. Is it still being triggered by that? Or is it just something where the immune system is dysfunctional, even though COVID has been completely cleared from the system? And a lot of, I have to say, some very bright people are doing these studies. And in the coming months, there's going to be the opportunity for a lot of individuals suffering like this to get into those trials, to get help. And what about right now, right? Because that's the future. There are a lot of long COVID specialty clinics that have sprung up around the country. And so the Mayo Clinic has one, NYU has one, Mount Sinai has one, UC San Francisco has one. You guys need to have one because it can't just be specialty centers, because as people with questions are, you live in a certain area, you can only do so much through telemedicine. A lot of times you need to sit down there face to face with a clinician and have that connection for them to really understand what's going on. But there are things that clinicians can do. It's been 18 months, so we're learning things that help people with long COVID.
Great. We have another question that was emailed into us from Walt from Oakland, who has been listening to your show on his dog every Saturday for many months now. And he was interested in learning more about how we deal with new information and how you, in particular, as a clinician, parse the information that's coming at you. How do you separate the wheat from the chaff, if you will, without getting stuck in bureaucraties? How do you parse your information?
Yeah, well, thank you for listening to our podcast. We started off with it being a clinical update, like 30 minutes, but we've bumped it gradually to 45 just to increase the fitness level of our listeners. And also the dogs love it, make it a little extra sniffing time. But no, this is a challenge, actually. And I think that this is, I'm grateful that I not only got the MD, but more that I got the PhD, because an MD is really, memorizing lots and lots of stuff. The PhD in many ways is learning to think. It's learning to analyze information. And I have to say my undergrad degree in philosophy has come in quite handy. It's a challenge to go through the medical literature, to understand, what study is helpful, what isn't. And as I do my weekly updates, a lot of times I'll be, putting an article in, going through it, and I'll get to them like, no, this does not make sense. This is not valid. And then, delete that whole page and go back again. So hopefully, it's sort of I'm reading the medical literature so you don't have to. And I'm fortunate that I was trained to read the medical literature because it's not easy. And I have to say, one of the most, there's several frightening things. One is, the physician says, in my experience, right? That's, a string of anecdotes, which plural of anecdotes is not data. But the other, right, is the, do your own research, which I'm not sure what that really means, because how many people can really access the medical literature? So, if your car is broken, go to a trusted mechanic. If you have a problem with your teeth, go to a trusted dentist. If you don't trust the dentist, pick a new one. And I think what we've tried to be here with This Week in Virology is a trusted resource. And it's not just me. When I do the This Week in Virology, we also have Vincent Racaniello, youngest tenured professor at Columbia, and he's a sharp virologist. We have other people. So, you don't get to just say anything in a vacuum. I think it's good to have colleagues that are going to say, yeah, I'm not sure I would take it that way. And so I think that's part of getting through it, getting colleagues to help curate the literature, getting colleagues to be critical of what you have to say or think about it, because you've got to come to it with that humility. And hopefully there's some success in what we do each week.
Thank you,
Awesome.
Dr. Griffin. I see Professor.
Looks like we were Zoom bombed
Yes.
by that Greg Johnson guy.
Yeah, well, here I am. No, listen, time is running out on us, but this has been so fantastic. I've learned a lot. I know our audience has as well. But Professor Hom, I didn't want to cut you off if you had an additional question or a wrap up. Before I ask you both a question, the unanswerable question, but the one that needs to be asked, about how do we attempt to continue to reach the non-vaccinated or even the anti-vaxxers? What shifts in language, what shifts in thinking and disposition might we adopt to do this rhetorical work, this persuasive work from your different perspectives, a university professor, a clinician, and a scientist? And let me give some context. When I hear about the non-vaccinated or the anti-vaxxers in the abstract, I think, well, who are these people and what's wrong with their thinking? But my wife and I did a little bit of research this summer in Hawaii, in a community we know and love, with some of the smartest people we'll ever be gifted to know, deeply smart organic intellectuals. Many of them are strongly against being vaccinated for all kinds of principled reasons. Many of them can be distilled to suspicion of the state and state messaging and the authority of the state, and this gets attached to that. And I think one-on-one, we can attempt to disentangle that, think that through, whatnot, but it's really a widespread thing, and it struck us both that so many people we admire and who are so deeply smart should be that reluctant to embrace the authority of science because of its elision with the authority of the state that has time and again abused them. We've talked about colonialism and so forth. So that's really the context for why I would ask the question this way. But any insights you might have to how we shift our language practices, our compassion practices, and so forth, to better reach people when we're otherwise failing. I failed. We failed in our conversations. People I'm normally able to be perfectly frank with and expect a reasoned response, we didn't get there. So any tips either of you might have?
You go first, Stephanie.
Sure. I'll go first because I have an experience with this in teaching my course last year. So what I tell my students is that, my classroom is always a cocoon where we should feel safe to voice our opinions. And there will be times that come up in the classroom when we disagree with one another. And it could be, we could disagree to not violent extreme, but to disagree to extremes. And I ask my students that before we immediately react, instead of reacting, we ask that person that we disagree with, please tell me more. Because if we listen from a place of deep respect and we listen with the belief that everyone's perspective is worthy, then perhaps we will be able to move beyond this rigid polarization that we've gotten to. And last year in my class, it was before the vaccines were developed, we were having a bioethical debate about whether or not one would get a vaccine if it came out or not. And I had several students that said, well, I've already had COVID, so I don't need to get the vaccine. And I saw the faces of some of my students go like, oh my God, why not? But they remembered and they said, well, please tell me more. And we had this really interesting debate. And over the course of the quarter, several of these students came around and said, oh, you know what? I think I might get a vaccine because it won't be just about me. It's going to be about my grandfather. It's going to be about my uncle. It's going to be about the rest of my family. So it was instilling that structure of let's listen to each other from a place of deep respect and not just immediately dismiss somebody else's thinking, that would then open that door just a crack that will help us to continue the conversation.
That makes perfect sense. And you said it so well. Thank you for that.
Yeah, that was fantastic. I'm going to agree fully. I'll start off with another quotation. When you have a vaccine discussion, be as ready to learn as much from the other person as you expect them to learn from you. Right? We often go into these conversations with our list of facts. We're just anxious to get all those facts out there. But you should probably try to listen and learn as much from the other person as you expect them to learn from you. And so, on my last This Week in Virology, we had a portion that I dedicated to the discussion with a pregnant woman. And about 85% of pregnant women in the United States are unvaccinated. And what I liked about talking about that population, these are not the anti-vaxxers, right? This is pregnant people. And why are they not getting vaccinated? And if you ask a pregnant person why they're not getting vaccinated, it's because they are trying to make what they feel is the best decision for themselves, the best decision for their unborn child. And if you start to listen and and I have to say, it's very hard not to respect those intentions, those wishes. So they always say, oh, the best way, establish rapport. I don't think you establish rapport. If you actually are caring, if you actually care about this individual and can connect with them, then you can start having that dialogue. And it is a dialogue. If it's a monologue, you're in trouble. If you're doing all the talking, there's a problem. And so on the last This Week in Virology, I went through, okay, a pregnant woman is trying to make this decision. And I took this framework from a conversation I had with a pregnant person. They're trying to do what's best. So we started off with, okay, well, what are the risks? Is a pregnant person at higher risk? And we went through that they're much higher risk of ending up in the hospital, much higher risk of ending up on a ventilator. If they end up in the hospital, they're about 20 times more likely to die. So those are the facts. So as a pregnant person, boy, if at any point you slip and get infected, what a high risk you are facing. And then I went to the next, well, what about the vaccines? Because there's a lot of misinformation. Have they been tested on pregnant women? Is there any monitoring out there? And they've studied a lot of pregnant persons. They've shown that they are safe. They've looked for safety signals. And so it was really just talking and addressing what are the fears, what are the concerns, what are the questions that were shared with me by a pregnant individual, and trying to address those. And I think that we need to forget about this false dichotomy that the media is telling us, that there are these rabid anti-vaxxers. Most of the people, and if you look at the remaining people, about half of the people that are not vaccinated are interested in getting vaccinated, but they're not sure how to go about it. They're not sure what to do about transportation. They're not sure if they're going to get hit by a big bill. They have questions that no one has taken the time to respectfully address. The number of actual quote unquote, fixed firm, I will never get vaccinated. I'm not sure how big that number really is. And I think it's an illusion. There's an abstraction of the anti-vaxxer, but each one of the people out there that's unvaccinated is an individual. It's someone's mother, it's someone's sister, it's someone's brother, it's someone's uncle. Particularly the uncles, lots of uncles out there. And, if you have a respectful conversation, if you listen, the idea is if the information really supports vaccination and a person has access to information, they'll arrive there. If you have that dialogue and suddenly come across some information that makes you hesitate and says, oh, this might be a little different. If you're not going in willing to have that open mind, why would you expect them to have an open mind?
Yeah. Well said. Food for thought, no doubt. I would say I would push back just a little bit, Dr.
I was
Griffin.
hoping you were going to push back a little.
In
We're being
some
much
contexts,
too friendly here.
I think there are some social and cultural contexts where the reluctance is more deeply embedded, is more collective, has more layers of history behind it, as I gave the Hawaii example. So I think there is a collective will that resists anything that looks like state authority that's happening here. But that's a specific kind of instance.
No, I think you make a really good point. Like, I'm a white male, and I am not the right messenger. Science, right? We have sort of a cultural issue. You trust people that you trust. And so if you want to get vaccine information, you want to get that vaccine information from someone you trust, not from some white guy that you just walked in the room with. And so there's a lot to what you point out is if someone in your community, if you and your community decide to embrace vaccines, that's quite a difference. And that's a little bit of the risk with vaccine mandates, right? I mean, now you're taking what kept people vaccine hesitant and you're shoving it down their throat.
Yeah, absolutely. And I think that's going to backfire time and time again, as we've seen in a number of places. But where you're talking about the messaging, absolutely. In Hawaii, there has been some movement where various entities have found members of the community who are otherwise against vaccination, found those who are being vaccinated, celebrated that choice, getting that out there. How successful that's been, I don't know. But the basic premise that you have to be part of that community to shift the view of authority within it, that's critical. Well, listen, we are at that time I like least about Zoom, and that is that you can't see the gratitude of the audience in front of you. I can't see them either, but I'm quite sure that they've learned a lot, as have I, that people are grateful for the gift of your time, both of you, and for the wonderful dialogue you've engaged in. Thank you both for the energy you brought to this and the time you gave us. And we'll say goodbye. I wish I could say it for all the audience members. Soon we'll be back in person. We'll welcome that day. But thank you both, and take care.
No, thank you very much. Thank you very much.
Okay, good night, everybody. And check our website for future events, and be safe until then. Okay, good night.